Hello everyone, thanks for joining our webinar today. The IASSS is proud to present to you our first ever surgical skills workshop, Introduction to Surgical Skills. We are proud to have Mr. David O'Regan with us today. He's a cardiothoracic surgeon from the UK and he's also the founder of the Black Belt Academy Surgical Skills. Without further ado, let's welcome Mr. David O'Regan.
There is a factory that takes the valves from abattoirs, and the abattoirs actually are involved in the Marks and Spencer's food chain for the delivery of healthy, edible food, top-of-the-range food on your plate as a customer. Those pigs are selected for their valves, and the valves are taken out and tested, and then put into a pot, having been dissected, and they put in a pot. And these pig valves are then hand-stitched by a group of 20 Filipino and Malaysian women who are absolutely adept at sterilizing and stitching the valves. This is done in a room, clean room, that has 24-hour monitoring of particles. They have double doors like an airlock on a spacesuit, going in, stitching, preparing the valves, and putting them in the pot. Those pots come with a barcode on it, and the barcode informs the universe, the consumers, the hospital, the patient, and everybody else when the valve is taken from the pig, the dates and times, and the conditions under which the valve was prepared and made ready for an artificial valve and put in the pot. And that information is on a barcode that, should anybody have a problem with the valve, they scan the barcode, and the manufacturing details of that valve should be available within 24 hours to enable people to track the valve. That is the condition under which heart valves are made. And that is actually the condition under which every implant in surgery, whether it's a heart valve, a hip replacement, a bit of gauze, or anything that goes in the body, needs to be put in. Now, from an industry standard, that standard has to comply to a Six Sigma standardization, which is 6 decimal places. So if you imagine your Gaussian curve with 1 standard deviation, 2 standard deviation, 6 standard deviations, the quality control in making that valve is part of the kite mark, CE mark in Europe, or the quality mark you find in any part of the world, necessary, defined by the FDA, NICE, or whatever regulatory committee, to be safe to put in to a patient. The next time you look at something on the shelf or an implant, you need to think of that. That is the industry requirement. So if you then, as a surgeon, a cardiac surgeon in theatre, you've got the patient, the chest is open, the patient is on bypass, the heart is stopped, you've opened up the heart, you've taken out the diseased valve, and you're now putting in an artificial valve. Pause for a moment and just think a simple question. The conditions under which we take the valve out of the pig to put in the pot, and then take it out of the pot to put it into the patient, which should be more stringent? What do you think? Hit your like buttons. like? Or is it the pig into the pot, put your likes up now? Or is it like from the pot into the patient? Now, the surprising thing is that from the pot into the patient does not equate to the industry standards at all. And indeed, I did a study where we looked at this. And in the theatre that I operated in, 95% of the areas that we swabbed and surfaces did not even reach one standard deviation. Not even one standard deviation. The other 5% had bacterial counts in the surfaces that were too numerous to count, including the washcloth, the box that served the gloves, and the stainless steel trolley on which the surgical instruments were served during the operation. Too numerous to count. To be honest, to take it back to more practical levels, you buy a sandwich from your corner shop. The conditions in which the sandwich maker and hygiene conditions are more stringent than the conditions under which we operate on people. To be honest, the sterility in theatre is such that you wouldn't even be allowed to make a sandwich to sell. We've got a problem. So for some reason, fundamentally, and I think this is universal, just because we're doing surgery does not mean to say that we should not be meeting industry standards and quality. So next time you buy something, next time you eat a sandwich, just think to yourself, the hygiene conditions under which those are made, and the sandwich you eat is going into your body, and you expect to be clean and free of bugs. Now, with that mindset, you as a surgeon or surgeon of the future are now going to walk into a theatre to do an operation where you're going to take a knife to the skin being the most remarkable barrier to keep out bugs and protect you from the nasty germ-free environment. You are going to break that down, operate on somebody, and expect an outcome. So, rule number one, your incision, the scar that you make on a person, and I've got a scar on my neck here. I had an operation, fusion on my neck. And Jake Timothy was one of my trainees. And Jake did my operation. And I said to him, I trust you. He said, one of the side effects of it is I could cause paralysis. I said, no, I know that's a side effect. I accept that. That's part of the risk of the operation. And a wound infection is preventable. And I said to him, I accept that risk. But if I have a wound infection, I am going to sue you. Because that is preventable. That is something you can do as a surgeon. That is part of what we can manage in surgery. Now, how do we go about it? Well, I've talked about the theatre, the environment, the air, the conditioning. What's interesting, the microbiology people in the hospital said, we only do the sterilization tests and bacterial tests in the theatre is empty, which is absolute nonsense, because when they took the valve out of the pig and put it in the pot, that monitoring happened 24/7. And if they deviated from 6 standard deviations, the factory would be closed, they wouldn't be allowed to sell valves, and no way could you put it in the patient. So it's very interesting, this compare contrast between what we expect and demand of industry, translate that into what we feel and see in hospitals are two totally different things. But we as surgeons are responsible for that. And your scar is the indelible signature on a patient for the rest of their life. And consider this for a moment. You might not remember that particular patient. You might not remember the detail of the operation. You won't remember their name. But that patient for the rest of their life will look at their scar here, and they will remember you. That is your signature on that patient for life. So therefore, everything you said, everything you did, every interaction will be remembered by that patient. They'll look at that and say, and I know that. Here's my technique. That I put to you as a simple philosophy is what we should think about when we think about the privilege of operating on the patient. That brings me to the next point. The next point is very simple. I've sat in MDT meetings when we have discussed wound infections. And I've had colleagues that actually said, oh, that's not a wound infection, that's a bit of an ooze. Oh, that's not a wound infection. That was culture negative. Oh, that's not a wound infection, it was slightly red. Oh, that's not a wound infection, it's a bit oozy. We have got a serious problem, folks. If we actually start thinking, I'm sorry, I've got something on my screen which is interrupting me, and I need to just got it. Thank you very much. So, if we accept and make an excuse, then we allow for something that's not right. So I want to challenge you in your thinking. Anything less than a perfect wound, no discharge, no seroma, no redness, no pus, no gaping, no scarring, no keloid, anything less than a perfect wound has cost patient distress, cost patient time, cost the patient anxiety, but it's also cost our health system blessings, time, and investment in staff to actually deal with that wound. So I want to ask you something very simple. Please, 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 in the future, do not debate anything less than a perfect wound. And if you are delivering a service and making an incision in patients, it's beholden on you to show me that you are delivering good wounds. And this is where audit comes in. So I have, in my 25 years of cardiac surgery, delivered a wound audit for discharge, but not only discharge, the long-term outcome. And therein lies an interesting thing. In 2009, my trainee chastised me for putting bone wax on the sternal wound edges. And he said, why are you putting this artificial material between two bleeding healthy bits of bone? Think about it, in orthopedics, any artificial material between two bone edges is going to cause a problem. And he said, why are you doing that? And I thought for a moment and thought, you're quite right. And that is the problem with much of what we do. It's because we have always done it that way. We've always done it that way. So in no uncertain terms, I was chastised for putting bone wax on the sternal edges. So we started to think, what are we going to do to ensure that the tissues heal and have the optimal conditions for healing. What is involved? So in 2009, we introduced the tissue care bundle to reduce healing. The first one was the PrEP. And the PrEP, I previously used iodine in surgical terms, in historical terms. We used to splash this on and called it holy brown. Holy brown iodine, go on there and do it off. What was interesting is most surgeons would splash this on, the holy brown, the iodine, povidone iodine. But actually you have to wait for it to dry to be effective. And I don't know of a single surgeon who can stand there for 5 minutes doing nothing, waiting for the iodine to dry. So what they did was wipe it off. And then proceeded with the operation. The New England Journal of Medicine has published an article showing that chlorhexidine is far superior to povidone iodine. And that is a nice recommendation. I must admit that I was a laggard using chlorhexidine. It came in an applicator with a sponge on it, and I didn't think that was enough to cover the patient. But it did. So I started using chlorhexidine, and the great thing about that as well, it dried quicker. So I didn't have to wait for it to dry. The next thing I did, as I thought about the incision, is sharp dissection is clean dissection. We take the knife through all the tissues. So I took the knife as a sternotomy, 22 centimeters, perfectly perpendicular down the middle, with a knife only. No diathermy. Too often people actually go through each layer of the skin with a knife. 7 layers. So if you're going to do that, do you know the 7 layers of the skin? Can you name them in Latin? And what is their function? That's your homework for tonight. Go away and learn that. I want you to take a perfectly clean, sharp incision through the skin. So if you watch the Black Belt Academy, and I'm talking about that in 2 weeks' time, the finest cut on metal. So join me then, and I'll explain in principle. I recall Mr. William Walter Frederick Southwood, who was my trainer in Bath in 1987, when I asked him to do, if I could do a Ramsay procedure in children. He said, yes, but we need to teach you how to use the knife. The knife has got to go cleanly through the tissue without bacon slicing it. Clean, sharp dissection respects the tissue. The problem is that many, many people, having made a scratch in the skin, would take the diathermy and go fulgurate all the tissues all the way down. Not only does that actually damage the thermal injury to the tissues all the way through, but you get a lot of smoke, and we now know that the smoke is carcinogenic to the surgeon. But there was a surgeon in Midwest America who very simply removed the diathermy from his incision process, and with a knife cut through the sternum and reduced his wound infection in half. So I used chlorhexidine. I used a clean cut to the sternum, no diathermy. I did not put bone wax on the sternal edges. And if you look at the surgical site infection bundle, they said make sure the patient's warm. Now you know this. When you get cold, your fingers go white, don't they? They go white because of vasoconstriction. The same applies to a wound. When you're cold, the wound itself, there'll be peripheral vasoconstriction, and the capillary beds will be shut down. But you need the blood. You need the capillaries in that area to help with your healing. And in America now, it's mandatory that every patient has a warmer on them to ensure that they have good temperature to enable healing, and failure with that warmer, you will be sued. Cardiac surgery was always excluded because hypothermia was part of the tool that we used to protect the organs when shutting off the circulation and stopping the heart. And it was exempt. So what I did is I let the temperature drift, but I did not let it go between 34, and I actively re-warm on closure. On the stone edges, I put flow seal that had thrombin in it, and thrombin is a fantastic catalyst for stimulating coagulation and also your complement system. It also stimulated osteoclasts and osteoblasts. And then, in closure, when we operate and bring tissues together, I use this sign, Namaste. You bring them together. You do not squeeze your tissues like that and strangulate them with continuous sutures. So your surgical technique and the way you respect the tissues in your closure and in your handling is important. Just as a deviation, the center of your forceps. The average pinch pressure, like that, between your finger and thumb, like that. Pinch yourself. It is an aversion technique, and if you're being attacked, if you want to actually pinch somebody on the side of the thigh, it's extremely painful. You are employing two important muscles there, the flexor digitorum profundus and the flexor pollicis longus, that are the Popeye muscles of your forearm. They're the biggest muscles in the third deep compartment of your forearm. These are the muscles that people use to hang on cliff edges. That's what they're used for. For surgery, I don't want to see this biting. That pinch pressure is delivering 30 newtons at least. And if you take the surface area of your forceps at the end, the surface area of your forceps at the end is 5, maybe 6 times 10 to the minus 6 meters squared. So that means, going back to your basic physics, and you were there before I was, that physics means that you are putting a pressure of 5 million, I'll say that again, at least 5 million newtons per meter squared, simply grabbing your forceps in the wrong way. The muscles that we need for tissue handling do that. In the chat room, can anybody actually name those muscles? Nizar, which muscle does that? Which muscle does that? Go on. Which muscle extends the distal interphalangeal joint?
Bronchoradialis?
Sorry?
Bronchoradialis, maybe, I'm not sure.
The lumbricals, sir. The lumbricals. And what's so special about the lumbricals is that they don't have any bony insertion or bony origin. You can't pinch with it. But what's beautiful about that in the opponent's pollicis, you can bring the tips of your fingers together. And surgery is all about respect to the tissue and using the tips of your fingers. You're bringing the palps of your fingers together. And there's more sensory input from the palps of your fingers to your brain than there is from your eye. And that is a fact. So your skills as a surgeon is going to dictate how you respect the tissues and how you clean them. And then, of course, afterwards, you've closed the wound and the skin should be perfectly brought together. Now, 24 hours, the skin is actually waterproof. They can step in the shower and get up and move around. Because think about the basic pathophysiology of healing. The wound heals provided it's got oxygen, because the peroxide generated by the mast cells and tissue cells are the natural sterilization agents. And it also needs blood. So for every surgeon doing whatever discipline you're doing, you need good blood supply, a good heart, and you need good lungs to carry the oxygen in the blood to that area. Of course, that is why a surgeon should carry a stethoscope and listen to the heart and listen to the lungs, because that's going to determine the outcome. But we also know that if you're sedentary post-op and you're not doing anything, basal atelectasis, where the lungs collapse on their weight in 4 days, lack of mobility, lack of the blood going round, is not going to help the wound infection and wound healing. The good book said, take up your bed and walk. And so you should. I was very fortunate in cardiac surgery. We don't interfere with the bowel. We don't interfere with the limbs. We don't interfere with the breathing. So from my point of view, the patient had no excuse not to get up and walk. And we did a simple study. Everybody's got these airline seats, TV screens, to keep them entertained as patients in the hospital. And I randomized people into TV on, TV off. What was interesting, the people with TV off walked 5 times more further steps than the people with TV on, and they went home earlier. So my simple philosophy for cardiac surgery was walking, talking, eating, drinking, bowels opening patients go home earlier.
I'm sorry for interrupting, doctor. Sorry for interrupting your thought. We just have a question from one of our viewers. It says, hello, sir. Is it possible that someone can perform surgery once he's missing a thumb on his one hand? How would you answer that?
From the surgery point of view, yes. I think you can adapt if you are missing a thumb. Just think of the marvelous things people are doing in the Paralympics. And I watched the Paralympics with people with missing limbs, missing that. Think of what they can achieve. The answer is yes. Okay? Not an issue. So I wanted to give to you a context within which this whole thing sits. This is not just the individual, it's the system, it's the patient, it's the way of thinking. It is a multi-system thing. But you, as a surgeon, are making that decision, and you are going to be responsible for the outcome. And I'd like you, therefore, in your thinking, compare, contrast that sandwich you buy from the shop, the quality control markers required, what you're doing in theatre, and how you're organizing the team. So that is an overview of what I think are the major issues with wound healing, wound infection, etc. So let's get down to a few specifics. And the specific that Nizar asked me to talk about is sterility in theatres and how to gown, to scrub up and drape. And I'd like to talk you through some basic principles there. What was interesting in cardiac theatres, we have a positive laminar flow through theatres. And in many orthopedics theatres, they wear Charlie suits and Charlie theatres that actually control the air going through theatres. And as you see the flaps in theatres with a positive flow from theatre to out. So every time you open the door, you are actually increasing the traffic through theatre. And I did a study where we looked at the number of people coming in and out of cardiac theatre over an hour. And we had 60 door openings in that hour. That's not a door opening, that is an oscillation. What I tried to do, try and stop that and say, you are only allowed in theatre if you can name the patient, name the operation, and their age. In other words, you had business in theatre. But traffic through theatre is important as far as infection in the environment is concerned. Because we had long operations, many of the anaesthetists turned newspapers. Each time you open a newspaper, 10,000 particles go into the air. And there's people from the laboratory which put the valve from the pig into the pot, measured these things. But that is adding to the aerosols in the air. So we wear masks. And the whole thing about masks is not stopping microbes. The mask is there to stop the nasal drip and the spittle in talking. It happens with everybody. So if you're going to sneeze, don't turn your head to the side because the exhaust goes behind. Sneeze into your mask, it goes behind. If you turn away and sneeze, you'll be sneezing effectively backfiring into the room. And that is why we wear a mask. It's not keeping bugs or bacteria or viruses out, not at all. It's just stopping the spittle. So in other words, when somebody's coming into theatre and peering over the top, please wear a mask so you're not spitting in the room. Right, let's move on to simple basics.
Can I interrupt you again? I'm sorry, because it's a live video. We have another question about what you just talked. Hello, sir. So if there are so many people coming and going, what about the risk of infections? Isn't it dangerous for the patient? Someone asked.
It is, yes. You've got to control traffic in theatre. And I believe that can happen with briefing. Only those people involved in the operation should be there at the briefing. If you haven't been at the briefing at the beginning of theatre, you've got no business in theatre. And therefore, if you can't name the patient, the operation, and their age, I personally don't think you should be allowed in theatre. That just removes the casual walk-in person, can I have a look? And that is important. So there needs to be a certain discipline within theatre, and you need to role model that yourself. I have to laugh. Many of you know Harry Potter. Harry Potter and Severus Snape was talked about having black greasy hair. Would you go to a hairdresser that had black greasy hair? I don't think so. Would you go to a dentist that had halitosis and rotting teeth? So therefore, your role as a surgeon is you got to be clean cut. And I know, Nizar, you sport a beard, and I do too, and everybody condemned the beard during COVID because the mask didn't fit. True. The beard is problematic because we inadvertently scratch all the time. Very fundamental to all of this was Florence Nightingale back in the Crimean War simply identified washing your hands with soap and water is the only thing we need to do. And while we deviate from that subject, it actually distresses me that people put on gloves to examine patients, etc. As long as you haven't got an open wound on your hand, soap and water will kill 99% of all the bugs and germs there. Do not put gloves on to examine a patient because then you are saying dirty. And I say, just on the side, you don't put gloves on as part of your own toiletry. I must say, I was at a surgical conference, I saw people holding their mobile phones at the urinal. I've never seen this before. If you want to know something dirty, it's your mobile phone. Hands are dirty. Hands carry germs everywhere. So before you examine a patient, you wash your hands. Once you examine a patient, you wash your hands. not only is that actually reducing infection, but I believe it's a mark of respect to your patient. I'm here to serve you. I'm going to be clean. You would not let your dentist operate on you otherwise. So in that regard, you've got to look the part. There's a certain esprit de corps. Cut your hair back. Be clean. Remember that all piercings and makeup and mascara can introduce that particle count as if opening a newspaper in theatre. But look at your nails. I don't mind what your hobby is. You could be a car mechanic, and Chris actually put a big engine into BMW Series 5, and he was a car mechanic. Terrific. He was brilliant at it. He actually reached a motor magazine. He had grease all over his hands. But what he did was meticulously take the grease off before he came to the clinical environment. And that, too, translates into your nails. They are short. They are clean. And the first step with scrubbing up is turn the taps on, rinse your hands, and you got within those brushes a plastic scraper. And I love the German word, Nagelringer. I just like that. A Nagelringer, which is actually to take the dirt from underneath your nails. You've got a brush at hand. Keep them clean going into the clinical environment. What's interesting about the water on the taps in theatre, there's a simple principle behind scrubbing up to come to a table. As you scrub, you've got to think that your fingers and your hands, the distal bits, are the cleanest. So you're holding your hands up all the time. So as the water comes off, it's dripping off your elbows. If your hands are below your elbows and you're washing, the dirty water will come from your elbows, which are dirty, to your clean hands. So the simple principle is why people walk around this like this in theatre is dirty, clean. Because the water's run from there to there, clean. Fundamental principle is scrubbing, which is also problematic when you think of the ergonomics of how the taps are put in theatre. And certainly in one theatre, the Nuffield where I worked at, 3 cardiac cases a day. At the end of the day, my back was sore because I was bending down to try and get these taps working for me to keep my hands above my elbows. The other thing was also interesting. I was not accused, but people would point out that when I scrubbed, the floor was incredibly wet. Yeah, I didn't want my greens to be wet, because when they're wet, then the barrier between me and the patient is actually compromised. So I'd held them out to the side. It went on the floor, but I wasn't wet. So intrinsically, I was clean as well. The scrub up technique is soap and water. Whether you use chlorhexidine or whether you use povidone iodine, the principle is the same. And if you've ever done those microbiology studies using ultraviolet light to see where you miss out. The missing out is at the tips of the fingers, in between the fingers, the palm of the hand as well, and the interossei. So your scrub up technique should be deliberate, and I'll describe mine. I would go to the tap, turn them on, scrape my nails, hands in the air. I then do a good lather wash from my hands down to my elbows. And I do that twice for a minute, 2 minutes. I then do a wash, and the brushes that you're given, you've got a sponge one side and a brush the other side. You may use the sponge, but please do not use the brush on your skin because it excoriates and increases the bacterial count. Do not ever use the brush on your arm. So my first thing, scrape the nails and I brush my nails. Both this side a minute, this side a minute, making sure that I move my hand round so I get round the curve of the nail. Wash down. And then wash my hands from the hands to the elbow. And the wash is deliberate. The deliberate wash between the fingers, back of the hands, both sides, on the thumb, and I do that 3 times. And I wash off. If I touch anything in the meantime, if I compromise that, I add another wash. No compromise whatsoever. So, then you've got clean, I hope, hands, and you've seen the TV programs. They all stage this, don't they, in the TV programs. You have to dry your hands. So, for the purposes this evening, I've got a table napkin, and there comes folded your paper towel. There are 2 parts to this towel, and this is important because you've got to remember your fingers and hands are clean, your elbow is dirty. Friction and rubbing is going to cause, a bit like the brush, excoriation on the skin. So therefore you're dabbing this dry. So you've got 2 towels, one for the right hand, one for the left hand. So I take top half, I take each finger, and I make sure that each finger is clean and dry. That's the top half. Nice and dry fingers. I drop that, I take the bottom half, and then round the elbow, both sides, dab it dry. I'm not rubbing, to the tip of the elbow and discard. Now, I did that deliberately because what I find is many people, having got to the elbow, then scrunch it all up and throw it away. You scrunch it all up, you're now mixing the clean side, the hand side, with the side that you got to the elbow, dirty. And you're going like this. That defeats the object. You're going from your fingers down to your elbow. And you're doing that for each hand. You're now hands in the air, clean. I sit behind to actually see people scrub up, and I watch them. I do not want anybody coming to the table with dirty hands, not at all. And therefore, if you're not scrubbed up properly, do it again. No compromise. Think to yourself, is this going to be my mother, my father, or anybody? So within a gown pack, you can see it on my ironing board here. I've just demonstrated within the gown pack. Here is the white towel. I've opened it up. Top half of my hand, 1, 2, 3, 4, round my hand, drop that side, pick this up, 1, 2, 3, 4, 5, 6, and I drop it in the bin. I do not scrunch it up. The gown is folded. So again, simple principle. The outside of the gown is sterile all the time. You can touch the inside. So therefore, the way you put the gown on is important. I've moved the ironing board out the way because the scrub out rooms are small. And to actually do this, you need a bit of space because the outside of the gown must be sterile all the time. So the gown is folded, and what you see is the inside. And that's the outside there, but I got my hands on the inside there. Okay, let me just open up the gloves for a moment in preparation for the next. These are all opened up for you on a sterile form by someone else opening up because they're in 2 layers among them. So I pick my gown up That's the outside. And there you go. I can shake it out, making sure that I'm not touching anything at all. And the process is to shrug it on. See that? My hands have not come to the outside of the gown, because the outside is clean, inside's dirty. And I get somebody to tie me up. Now, tie it up comfortable, because you're going to be there for a number of hours and you want some flexibility and movement, and therefore your gown size is important. I don't have anybody to tie me up this evening. This is an important element. Finger and thumb between the cuff and the gown. I'm holding it like that. Okay? My hands are on the inside. I am now coming to the gloves. They're opened up. The gloves are folded such that there is a cuff. Okay, I'll show it to you. They're folded. There's a cuff there. That's the thumb there. Those are the fingers. I'm going to put that down on my left hand, and I'm going to grab the cuff there between my finger and thumb. I'm holding that tight. And it's thumb to thumb, and the fingers are down my forearm. And I'm going to fold the cuff over my gown and then open my hands out into the gown. You see that? My hands are now opening up into the gown. It's not on completely, but my hand did not come outside the gown until it was inside the glove. So the glove is clean, the gown is clean. The second one is somewhat easier. Again, there's the thumb, thumb to thumb. You hold the cuff, you take the cuff, you fold it over the hand, and you put your gloves on. You then can actually adjust your gloves. So therefore, if you're actually learning to do surgery, you want your gloves to be a comfort fit. You don't want these baggy bits at the end, all right? You don't want the baggy bits at the end. So you make sure that your fingers are comfortable within the glove. And I don't care how long it takes, but you get your hands comfortable within the glove. And correct. Okay. There you go. Obviously, I would have washed my hands and dried my hands, so therefore it's easier to get on because they're not sweaty and warm, etc. But I now got my gloves on. Okay, I'm gowned and gloved. Next important principle. So I've got in to my gown and gloves from the inside. I have not touched the outside whatsoever. This is sterile. Now, when you're walking around theatre and when you're gowned and gloved, you're going to walk around as if you were a monk or a nun. Your hands are sitting over your zippy sternum, folded, never crossed, not like that. So you can fold them. You never let your hands go beyond the anterior pectoral line. Do not ever let your hands go below the waist, and do not ever let your hands go above the nipples. Your hands are sterile within this very small space about the size of a regular TV screen. So when you're walking around, simply clasp your hands in front of you, walk around the theatre. You do not ever say like that. Take your hands beyond the midline, or you take your hands above. That is clean all the time. Now, just two things as well, because the reason we wear gloves is such that we do not actually transmit infections to the patient, but more importantly, any patient with hepatitis C is not going to give us as surgeons any disease. A single layer of gloves, single gloving, still maintains that sensitivity at the tips of your fingers. And if your gloves are correct, you're not getting strangulation or numbing of your fingers at the tips, because that's going to detract from your ability to feel. Because I've already said, it's all about feeling. You need to be able to feel your tissue. So your gloves are important. I did an operation, a coronary artery bypass graft, on a patient with hepatitis C. I asked the registrar to take the radial artery on the left hand, and they double gloved. I said, please do not double glove, because you don't regularly double glove and you'll lose the sensitivity. But he argued with me. I proceeded with the stenotomy, and I heard a plaintive voice that said, David, and I looked up. What he had done with his knife is slashed straight through the skin into the radial artery, and we had hepatitis C blood spraying all over the theatre. That happened because he lost the sensitivity. So I'd like to give you one bit of advice. Single gloving is absolutely fine. We do not deal with hypodermic needles in theatre. So your risk of inoculation or virus is extremely small, because the needles that we are using are not hollow tipped, and they're not smaller than the needles we use to take blood from the walls. Do not ever double glove. It will detract from your ability. In the end, we need to be able to feel our tissues. So I'm down. We now need to drape the patient. The prep is chlorhexidine. The drapes are put on the patient on the operative field because most of the bugs actually come from the patient's skin or the body habitus. So it'd be useful for you as a student to draw a body and write down from each area the common bugs you use, because the reason we give antibiotics is to mitigate those bugs being present. And those antibiotics and part of the tissue care bundle should be given 1 hour before the incision, and that is part of the checklist. So no matter what discipline you're in, please make a list, a little crib sheet for yourself. What bugs do you get on the skin, in the groin, the armpit? What bugs do you get in the upper bowel, lower bowel, the mouth, or whatever region we operate in? Because that is the antibiotic cover that you require. But stick to your hospital's guidelines for that. There's a reason. The reason for that, for the guidelines, is to target the infections there. The timing of that, the correct dose, etc., is important, because most of the bugs come from the patient. And surprisingly enough, not from the environment that I prescribed, or from you as a surgeon, unless you start spitting wounds. But that doesn't mean to say that you should not respect the tissues. So I introduced my tissue care bundle in 2009, when my registrar had chastised me for using bone wax. And we came up with this bundle of respecting the tissue, the temperature, the antibiotics, and everything I have described. We introduced that bundle, and on a shoe chart, tracking my all wound problem, not infection, anything less than perfect, went like that, and it dropped to zero. And it dropped to zero, a median of absolutely zero on every wound problem. from oozy, gaping, red, whatever, to 0. Beat that. That is what we aim for, is a perfect wound. Is absolute 0. And that doesn't come from one thing at all. That doesn't come from cleaning your hands properly, doesn't come from the antibiotic properly. It comes for attending to every single element of that pathway. It's the 1% of everything. The British cycling Olympic team was actually accused of cheating a few years ago when they actually took all the medals at the British Olympics. They didn't cheat. What they did was attend to the 1% of everything. They attended to the clothes, the cycle, the aerodynamics, the bike, everything. And the cumulative result of attending to the 1% of everything meant that they won gold medals. If you want to win gold medals, you want to ensure that your indelible signature on your patient for the rest of your life, their life, such that they look at it and say, Nizar, I remember you did that. That's what you want. And that comes from understanding the whole process, attending to what you can do as a surgeon, but being mindful of what you need to do within the hospital and the system in which you work. Do that, then I will salute you as a successful surgeon. Thank you.
Thank you so much, sir. We just have a couple of questions. I may read them now. Can you please repeat the German word for taking dirt out of nails? It's one question.
That word, I liked it because it had a certain alliteration as I read it. It was called, there's a plastic sort of scraper that you use to take underneath your nails. And there was a nice curved elliptical thing that you can use to scrape the dirt from underneath your nails, because you've got to get rid of the physical dirt first before you actually start scrubbing. And that was called, I think it was on the packet, Nachel ringer. And it just had a nice resonance to saying it.
Awesome. And another question is, how can someone manage complication of losing balance and shriveling while he or she is carrying out surgery?
Well, there are a lot of elements to operating. And what we don't think of operating in surgeons is a surgeon is effectively an athlete. Okay? And therefore you need to be sharp, you have to stay sharp. And there's one of the things I cover in the Black Belt Academy. Your own personal physiological fitness is imperative to this whole thing. Sleep is important. One night's loss of sleep means that you, the next day, are functioning as if you are intoxicated above the limit of alcohol. 2, hypoglycemia seriously impairs your ability to function. Make sure you start the day with a good breakfast, balanced with carbohydrates, proteins, and lipids. I did a locum job in a private hospital while learning from my Part 1 FRCS, and I thought it was just an operation. I skipped breakfast and I went across the road to assist. The operation went from good to bad over a period of 12 hours. I had not had breakfast. And by the end of that, the seminoproline became invisible and my ability to function deteriorated now. The last important thing that we don't attend to as surgeons is very simply hydration. We need to take a bottle of water with us to work and keep hydrated during the day. If your urine looks dark, anything less than pale yellow, or is malodorous, you are not drinking enough. And dehydration severely curtails your cognitive and motor ability. So if you are finding yourself actually dizzy or wobbly, you have not taken a break. When driving modern cars, if you've been behind the wheel for 3 hours, my car used to flash up saying, time for a rest. Beyond 3 hours, your physical, motor, mental abilities have deteriorated. So when you're operating, plan regular breaks, step back from the table, hydrate, and come back. That's easily said than done. As a cardiac surgeon, my longest operation has been 23 hours without a break. In retrospect, that was silly, that was stupid. There was a sort of bravado in this, that I'm macho, I'm a surgeon, I can do this. Hey, in the end, it's all about the patient and the outcome, not your ego. Ditch that. Look after your nutrition, your hydration, and I talked about athlete. Surgeons have to be fit. So what I teach with the Black Belt Academy is you have to stand up straight. Because every 2 centimeters your chin moves from the midline. You're adding 4 kilograms of weight to your head, such that 8 centimeters of the midline moving forward, your head is now weighing 19 kilograms more. The stress of that across your neck, your shoulders, and back is the reason why 27% of surgeons throughout their career will have a deleterious musculoskeletal problem. I've got fusion of C5 and 6 in my neck. I know amongst plastic surgeons, and I know amongst cardiac colleagues, that is 90%. So what I teach also in the Black Belt Academy is posture. And what really gets me is that we're teaching basic skills with people sitting down as if they're eating at the table. Very few surgeons, I'm in the Kibadeshi stance, horse riding stance for karate, and as third dan, we had us holding this for 5 minutes as a stress position. But your back is straight and my knees are 90 degrees. My back is straight, my neck is straight. If you need to go lower, think giraffe. A giraffe, when they drink, spreads their knees out. Not many of you will be able to hold a Kibadeshi position. But in this position, my neck is straight, my lumbar lordosis is maintained, my cervical lordosis is maintained. The other important thing is, explained, it is that movement that is necessary to tend to the lightness of touch and the feel of an operation. If you're operating with the elbows out by the side, you immediately have employed the major muscles of the shoulder girdle, trapezius, latissimus dorsi, pectoralis, supraspinatus, infraspinatus, serratus anterior, and all the other rhomboids, and you got major muscle fatigue. But what happens when you're doing that? We tend to lean over. Our shoulders roll forward. We get shortening of the pectoralis, major muscles. We got shortening of the sternocleidomastoid muscles. We get shortening of the hamstrings. In the end, you lose your cervical lordosis. And you end up with a lot of hunched up surgeons, yes, with severe musculoskeletal problems. So for you starting your career out, this is an aside from what we're saying, attend to your posture and also get fit. I'm going for the first part of my 4th dan in karate on Sunday, and I do 1 hour high intensity workout every second day to keep fit. Yes, I'm 62. The worst thing you can say is I'm old.
Thank you very much for giving so much detail about ergonomics and movement economy to our future aspiring surgeons. Another question because
And
we're
if you want
bombarded.
to learn more, please follow me on Medal. It's a free platform. It's live. I'm live on Monday evenings. And this Monday, I'm talking to a Niall Downey, who's a captain of Aer Lingus. He was a colleague in Cardiothoracic registrar, trained as a surgeon, wasn't progressing, and became an airline pilot. So that is going to be a very interesting conversation. You join me.
That's a very interesting, story. Excuse me, story about that. We have another question. Here, participant asks if you can add some details about your online academy, if it's on site or it's online, and
It's
what is
online.
the course?
It's online. It's on Medal. Nizar, if you could actually share that with you. Medal, MEDALL.org. You look on that, look up the Black Belt Academy. We are there. This is a platform that is hosting, empowering 1,700 organizations. There's a lot of free material on there, but the Black Belt Academy is there. All my catch-up lessons are there. You go to the website, BBASS. I'm on Facebook. I'm on Instagram. You'll see the exercises to help with your basic surgical skills. And like this evening, I enjoy actually explaining the philosophy and principles behind many of the things related to surgery. And I do it live to keep it fresh and hopefully keep you entertained. So Medal, MEDALL.org. I'm live on Monday evenings at 8 o'clock UK time, but it's recorded and there is catch-up. And I've gone to deconstructed all the basic skills and taking lessons from disciplines like martial arts and sports, etc. I am third dan in Weiduru karate, and here we go. When we talk about the knife, I'm second dan with a samurai sword, and yes, this is a live blade, and it is resistant.
Thank you so much for being here today. We will share all the details about the academy, every details about your live programs. Of course, guys, thank you for being here tonight. Thank you, Mr. David, for being here, dedicating your valuable time for us, teaching us so many important information about posturing and, of course, all our basics, asepsis, and all the package of information that comes along with that. It's very important for us, the inexperienced aspiring surgeons, to have the least amount that you provide for us, so we keep it as valuable part of us in the future.
It's been a tough time for everybody learning and everything, but I wouldn't do anything else than surgery. I could never be anything else but a surgeon. It's been a privilege. It's good fun. You're learning all the time, and that's why and it's a journey. It's a journey of mastery. You're always learning. So as long as you're learning and refining your skills, you're going to have a happy career.
Sounds very motivating. Thank you so much. Guys, thank you for being here. Don't forget to follow us on social media. Every detail is being posted in the email and the chat group. Good night, good morning, and good afternoon.
Good afternoon, wherever you are in the world. And I look forward to welcoming you to the Black Belt Academy live on Monday evening. Thank you very much for the privilege of being with you. I would appreciate feedback. So if you send that to Nizar, only with that can I actually think about how to develop the program and make it easier for you. Thank you.
Absolutely. Absolutely. Bye-bye, guys. Bye.